thought-provoking questions, and for some reason we're just trying to move through these, and they cluster into several themes. And we'll try to take them together as they come up. So I think I'll start with the biologics. Those are probably the most common. So let's phrase some of the questions, and if there's some repetitive aspects. So one question says, I worry about the side effects of long-term use of Remicade. What are the alternative natural medicines that could be considered? It's a very common question. So in terms of alternative and complementary medicine, whether it's naturopathy, aromatherapy, etc., we have very little data on this. This also relates to the role of diet. So a very common question in our clinic is, what's the role of diet in controlling your AS symptoms? There's actually very little good data on this. We're interested in initiating a study that looks specifically at nutrition. We feel very strongly that a balanced nutritional diet is an important part of the management. We have some patients that anecdotally have found that low carbohydrate and low starch diets seem to improve their symptoms. This is quite a recurring theme on the web if you go to some of the websites. But at the moment, we actually don't have good data on that at the moment. So that's a research priority for us. If a person's tried Emerald, Remicade, and Humira, which is 3, what are the chances that a fourth would work, like Symphony? So this is an important issue. As I mentioned, if you look at those graphs, the good news was 65-70% of patients respond to the first biologic, but 35% are not. Of those that go to a second biologic, about 50% will get a good response. There remains a small group of patients that seem not to respond to when 3 or 4 anti-TNF biologics have been attempted. We don't really know why that is. That reflects some of the heterogeneity of the disease. In fact, you saw even from ASA and Shira today, you saw part of the spectrum of patients doing extremely well with a rigorous exercise program and one that really needed that extra boost from the biologics to get the process under control. We think that that variability probably has a genetic basis, and that's a lot of what our studies. So what lies ahead? And that's a group of patients in which the anti-TNF class don't work. What's coming down the pike? So there's several new agents under study. These compounds block a molecule called TNF. There are other cytokines. One's called IL-6. One's called IL-17. So these are small molecules that the body produces in the setting of an inflammatory response. And so it's early days for some of these alternatives. Now the bar has been very set. The anti-TNFs are very effective for in this disease. But for those patients who, because of either side effects or a poor lack of response, need another look, we're actively looking for alternatives and working closely with our industry partners on that. Some of the side effects in terms of the studies being done in terms of does it reduce the progress of the disease? As I indicated, Remicade, Enbrel, Symphony, and Humira all improve symptoms, but in addition to that, they actually change the inflammation that we see on the MRI scan. So we believe it's not just a symptomatic Band-Aid that's controlling pain, it's actually making a fundamental difference in this course. And whether one of the, as Laura mentioned, one of the aspects of our clinic is to monitor X-ray progression over time. So in general, the bone spurs that occur in the spine in AS occur at a relatively low rate in most patients. So to capture the effect that biologics are having on that progression of the disease requires a long-term follow-up, and that's why we work very closely with our patients on regular X-ray changes to see, and we can certainly inform our patients about how things are changing. With respect to long-term side effects of the anti-TNF agents, so we have had Remicade and Enbrel on the market for about 10 years, Humira for about 7 years, and Symphony for about 4 years. So there's different lengths of follow-up. We and others in the international community are looking very closely at this question. When prednisone came out and it was discovered in 1948, it was given to patients with rheumatoid arthritis, and it was quite miraculous. Patients that had been wheelchair bound were getting up. And in fact, one of the discoverers of that got the Nobel Prize in 1949. But the problem was 2 or 3 years later, the side effects of cortisone started appearing, right? So high blood pressure, cataracts, high blood sugar, osteoporosis. And so that's a very important cautionary note for both the clinicians and the industry to watch very carefully, not just for early side effects, which we usually capture in the trials, but late side effects. So we're working closely with our colleagues in Scandinavia and Britain on what we call biologics registries. So now there are thousands of patients that are now systematically followed on the anti-TNF agents. And there was just a study published recently that looks very, very encouraging. The long-term side effects in AS, patients treated with biologics, are very minimal. So we're encouraged that both from the point of view of any late malignancies or any infectious diseases, that the long-term use of this does not seem to add over time to side effects. Indeed, the drugs seem to have a much better safety profile than they do in rheumatoid arthritis, which actually is a good piece of news for, if you had to pick a rheumatic disease to live with. So that's a very important issue on long-term safety that we have an ongoing dialogue with. And I would encourage you, as Michael said, accessing good data sites like the CSA website, the Spondylitis Association of America, SAA.org, and some very good follow-up data on a lot of these questions that we're looking at. What's critical in getting a patient onto a biologics? As Michael said, this has been an issue. The drugs are expensive, so they're $15,000 to $20,000 a year. About half our patients are supported by the Ontario Drug Benefit Plan, and half the patients are on private insurance. One of the very important dialogues that we have established in Ontario with the Ontario Rheumatology Association is to have a functional dialogue with the government. In the early days of biologics, there were, I would say, unexpected and unexplained barriers to accessing the biologics, particularly, and it was quite uneven across Canada. Happily now, these drugs are accessible in every province in Canada, but it does require that we document carefully the diagnosis and the previous treatments that have been tried. That is really a key issue. We're working closely with the government and third-party payers to make sure that there's not any Canadian with AS who, if they need a biologic, doesn't get it. And that's an important role, the advocacy piece that Michael talked about in terms of mobilizing support. In terms of travel, so the patient is off to mainland China, and the question there is, when you're traveling internationally, to what extent should we regard biologic treatment as a significant suppression of your immune system? Now, by and large, the good news here is the patients that get vaccinations, you can get a vaccination with a couple of exceptions, herpes zoster, but most vaccinations are well tolerated when you're on a biologic. And we basically encourage our patients to use the normal cautions of infectious disease protection when they're overseas. But we have had many of our patients travel internationally, either as a tourist or because of work. And happily, that's been, with those kind of cautions, we've not had any significant issues. We think of if you look at the frequency of minor infections of patients treated with the anti-TNFs, the course of, for example, even a flu or pneumonia or an ear infection or bladder infection is really not very much altered by the presence of biologics. So we think of it as a moderate suppression of your immune system. And in many ways, that guides our recommendations on infection. Okay, go ahead. So Laura's got a question.
Okay, so am I on?
Yeah.
Okay. So a question about accessing physiotherapy in Ontario. So there's publicly funded physiotherapy and there's privately funded physiotherapy out there. The publicly funded physiotherapy currently is through either hospital clinics, which unfortunately they seem to be closing a lot of these days, so they're fewer and far between. Generally with the hospital outpatient clinics, they're usually requiring a doctor's referral from in-hospital. So if you don't have, if your family doctor, say, isn't associated with a particular hospital, then you may have difficulty accessing outpatient physiotherapy in a hospital. There are a number of OHIP clinics out there. They're partially delisted, which means that the access is restricted to people under the age of 19, so 19 and under, or 65 and over, so you can access publicly funded OHIP if you're within those age groups. If you're in between those age groups and you're under Ontario disability benefits or other social benefits, you can also access OHIP clinics. And also, if you've had an overnight stay in a hospital related to a condition, you can access OHIP clinics. Again, they're limited in the province. I think there's only 55 licensed OHIP-covered physiotherapy clinics throughout the province. Otherwise, you're looking at pay out of pocket or having it covered through your extended health care benefits. And if you are, yes, thank you. Mary's over there waving her hand. There's also the Arthritis Society that I need to mention. They are covered through OHIP as well. And you can be referred by a rheumatologist, physiotherapist, occupational therapist, self-refer, thank you. And then, as I was mentioning, there's also private pay. So if you are getting your extended health care benefits, to cover that, you do need a doctor's referral typically. Okay. Another question that came was, how can I improve posture after 55 years of AS and a recent diagnosis of Parkinson's disease? We want to optimize posture. I think that's probably the best way to look at it. So you want to work with what you have and optimize that and maximize it. You want to prevent loss of mobility. So I want you to think of optimizing your posture and working with what you have. And in terms of Parkinson's, just on a side, so Parkinson's does affect balance and mobility as well. So exercise will also help in terms of your balance and your muscular control in terms of that. And then another study is, another question is, are you aware of any studies being done on the use of either laser light therapy or laser blood irradiation to help AS patients? No, I'm not familiar with those. And as far as any studies that are happening, I'm not aware of any. And then the last question here, are there support groups outside of the GTA? And I'm not familiar with any support groups outside of the GTA. However, I would suggest that you contact your local Arthritis Society because they're all over the province of Ontario, and they're probably the best ones to contact who can point you in the right direction in terms of what's locally available. And do you have anything to add to that, Michael, in terms of Ontario?
We have some local contacts for support. We do have some local contacts for support groups, and taking my Canadian spondylitis hat off for the moment and putting my Ontario Spondylitis Association hat on, which is part of the Arthritis Society, there are also these local contacts and one or two support groups. If you're out of town, I would encourage you to call us, being the Ontario Spondylitis Association, and just see if there's anybody in your area who is one of our local contacts.
Great, we have three questions relating to children. So one is, as a parent diagnosed with AS, how early should we or could we get patients checked for AS in our patient and our children? Should kids with AS parent be tested for AS even though they have no symptoms? And what's the likelihood of passing the disease on? So our recommendation to parents, it's a very common question in our clinic, is not to check B27 in the kids. Now, why do we say that? So if a parent is B27 positive and has ankylosing spondylitis, what's the likelihood of any kid getting one? So first off, the HLA B27 gene is on it's on 6 chromosomes. Well, so on any one child, there's a 50-50 chance the child will be B27 positive. But of those that are B27 positive and have an AS-affected parent, no more than 20% are going to be affected. So the calculation there is 50% times 20%. So that means that there's no greater than 10% chance that on any given child. And the way we phrase that, there's a 90% chance on any given birth that your child will not have AS. Why do we recommend that they not routinely check for B27? Because it's just, it's first off, as we said, you're going to live with that gene all your life, and it's not something we treat in and of itself. The vast majority of patients are individuals in Ontario that are B27 positive or asymptomatic. Most will not develop AS, hence the interest in the other genes. So our recommendation is that parents is to not introduce this routine testing, and our pediatrician colleagues and sick kids would have the same approach. Having said that, a kid that's actively involved in sports, and particularly in the teenage years, as was the case with our young runner from Peterborough, if there's an injury that persists, or if low back pain is not just a transient event, but turns into a more sustained event, or if there's swelling or pain in any other joints for an unexplained and unusual length of time, then by all means, those kids, whether they're children or teenagers, should see a rheumatologist for checking. What's the likelihood, if I'm B27 negative, what's the likelihood of passing the disease on? It's even less. It's about half of that. So if you have AS and you're B27 negative, it's a lower probability. A related question came up here. Will that, so about 10 to 15% of patients with spondylitis will be B27 negative. There's a trend towards slightly slower progression of disease and milder disease in the spine, and again, a lower likelihood of patients passing that on. In terms of, the question came up, is B27 more prevalent in North America and Europe than other continents? So yes, it varies quite widely. In the general, if you look at the global distribution in human populations, B27 is probably at the lowest level around the equator. And then as you get into northern populations like Northern Europe and Scandinavia and the northwest tribes of Canada, B27 is more common. The geneticists don't really have a good explanation for us on what that means. Does it mean that maybe this gene confers some better resistance to certain viruses? That, by the way, has been noted, that being B27 positive actually gives you a better chance of resisting certain viruses. If there's good news in an otherwise bad news story. Spinal stenosis. Do patients actually develop spinal stenosis? Now, this is a good question because not all back pain occurring in a patient with AS comes from active inflammation. And that's another reason we use our MRIs to try to discriminate that, because secondary disc disease or spinal stenosis actually can occur in patients with spondylitis, and we want to be sure that we're as precise in the source of the pain as possible, because it may be that the pain that what's not needed is a biologic, but rather consultation with one of our spinal surgeons. So we try to think very broadly about the AS, the cause of the back pain being contributed by other causes. Is polyneuropathy a feature of spondylitis? It's very unusual. That's a numbness and tingling in the hands and feet. It's a little clue for us that perhaps there's some impingement on a nerve in the spine. And contraction of hands and feet. We've made most of our emphasis in the discussion today has been on the spine, because that's the burden of illness for most of our patients. But contractures in small joints of the hands and feet can occur. It's uncommon, but we think it's part of the same spectrum. That the bone spurs that occur in the hands and feet can be a manifestation of the same process. In terms of in patients that have tried multiple anti-TNFs, can we say anything that the success rate or survival time on drug is better than any other? So at the moment, the 4 anti-TNFs for both effectiveness and safety profile are the same. So that's it's good news, because that allows us some options, and most of the decisions are tailor-made to the patient's own wishes. Remember, there's a variability in how the drugs are given. One's given intravenously, and 3 are self-injected. But as far as the long-term studies to date, which now are 8 and 10 years, I might say the large registries have thousands of patients that are followed systematically, and we're getting very good data on long-term safety. If you try 2 biologics without success, should you keep trying? It's a good question. Part of the answer to that question is why the biologic was stopped. So if somebody had an unusual injection reaction to a medication, they may be stopping that not because it wasn't working, but just because they've had an injection site or an infusion reaction, and that would be different. We have had patients that seem to have an initial response and lose it. That's a minority. But and we've even had patients such as this question implies, where they lost a response to the first two and a very successful response to trying a third. I'm already fused. Would biologics be effective? And the short answer is yes, depending on the goal of the treatment. So this has been a surprise to us, because the older textbooks of medicine, old being more than 10 years ago, used to say that ankylosing spondylitis burns out in the 40s and 50s. So it's maximal in your late teen years, 20s and 30s, and then it kind of burns out as it fuses. We've had a number of patients whose spines are essentially fused with a lot of bone spurs in the butt, but they have significant pain still. They have significant night pain. They're waking up at 4 in the morning. They're having 2 hours of morning stiffness. And when we've done MRI studies on such patients, there's still a lot of active inflammation. So the short answer to this question is, even if the spine is fused, if pain is a significant persisting problem, we actually have had very encouraging success with the biologic. Now, as far as we know, there's nothing that will reverse a fused spine, right? So none of these agents, indeed none of the new biologics coming on the market, as far as we knew, do anything to reverse the new bone formation once it's there. But we certainly know that pain can come, active inflammation pain can exist in the setting of a fully fused spine. So the short answer is yes, there's nobody that we wouldn't actually consider. How are we doing? So just about, let me see, 10 minutes. So there's a question here about generic biologics coming to the market. Interesting question. The two earliest biologics, that would be Remicade and Enbrel, will be coming off patent in the next year and a half. And then Humira and Symphony, the two newer ones, are farther down the pipe. What is that going to mean for accessibility and drug pricing? Very good question. Well, we got a couple of experts out there in the audience, but the short answer is that these are complicated molecules. This is not designing another ibuprofen or a Tylenol tablet. These are complicated molecules that are genetically engineered to create antibodies. So these are not, and hence the term, by the way, the reason they're called biologics is they're developed in biological systems. So it's very different than a chemist who's making Tylenol or ibuprofen or naproxen in a test tube with a set ratio of chemicals. These are actually generated in cells, and it's a very demanding and very precise process. Will there be so-called biosimilars that will be appearing on the market after the patent expiry? I think the answer is yes. The big question surrounding that whole area is what data will we have in terms of effectiveness and safety for the biosimilars as they come on the market increasingly. Final couple of questions. A patient that had a stroke, as far as we know, strokes, when you take a disease that occurs in over 400,000 Canadians, other diseases can occur by chance. It's a very important issue for us in trying to discriminate what events occur in the disease that are there because of the disease or just by chance. As far as we know, there's no fixed relationship to stroke and spondylitis. We can break all the rules for the last couple of minutes and actually take a couple of, if there's some pressing questions from the floor that we actually didn't get to, we'd be happy to take them. Yes?
How do I request one of these MRIs that show information from my rheumatologist? I think you mentioned that it's a special type.
Yeah, it's a special type, and the reason is most of our rheumatology colleagues, if the rheumatologist knows that the question being asked by the MRI is about spondylitis, and so the radiologist knows that what we're looking for on the MRI is there evidence of inflammation in the back. The reason that's important is that most MRIs done on the spine are done for disc disease, which is a very common cause of back pain. Right? So if the radiologist is not oriented to the question being asked, the report might say there's no evidence of a herniated disc in the back. But that's not the question. We're asking, is there inflammation in the sacroiliac joints of the spine? So there's a specific sequence called the Sturge sequence that we request when we order that. And we're actually doing some workshops at the Western now around the 5 universities with Queen's, Western, McMaster, and Ottawa to try to build these centers of excellence so the radiologists in these centers can actually have a meaningful conversation with the rheumatologist.
They were looking for, like when I had the MRI,
It was,
they were looking for anti-organ.
yeah,
So I don't know if they were looking for.
that's a good question. It's a very good question. Other questions from the floor? Yes?
Thank you very much. Excuse me, I'm coming from Europe and I participate in this conference. I'm very happy to be here. I have ankylosing spondylitis.
Yes.
And, I am on Embrel right
Yeah.
now.
Yeah.
And maybe you answered this.
Yeah.
But in Europe, they have 4 medicines, 4 types of
Yeah, right.
TNF
Yep,
blockers.
yep.
My question is, will there be some
New stuff?
biologics in the future?
Yeah, so the question is, a colleague is coming from Europe before biologics are on the market in Europe, the same in Canada. And what's coming down the pike, we believe that, well, the bar is set very high now, right? These are very effective medications in most of our patients. But for those patients that have had unusual side effects or a loss of effect, there's some new classes of biologics under study, which block not tumor necrosis factor, but other molecules like IL-6 and IL-17. So those are under study now. Those, by the way, these studies are lengthy and very expensive for the pharmaceutical industry. So if some very smart biologist says, we think we should block this molecule in spondylitis, that idea to roll out into a study involves different phases of a trial, and it's 4 or 5 years in coming and several $1 million to execute that. But it's very hopeful. We work closely with industry about thinking about what lies ahead.
Thank you.
Yes?
Do we think that the development of additional biologics will drive new forms of identification and diagnosis for early catch?
Yeah, that's a good question. So it relates to how this relates partly to the genetics too, for example. So most patients that are HLA-B27 positive in the province don't have AS, right? So that it suggests that there are other genes. And our studies with our geneticists suggest that what we might do much better for earlier diagnosis is not just to check for B27, but 3 or 4 other genes. There's one called ERAP, one called IL-27 receptor. So what we're working on is a diagnostic chip that could easily be done. Instead of just checking for B27, it's a chip that would check for 3 or 4 genes and would have much greater sensitivity for early diagnosis. So I think we're going to see some significant progress on early diagnosis coming down the pipe. Yes?
Are there any sort of known immediate side effects with the injections, with
The
the
local-
TNF blockers? Yeah, because
Yeah.
someone I know said that they suffer from a lot of dizziness, and when I asked my rheumatologist, she said, "Oh, that's very uncommon generally." people
Yeah, so the
have
question is,
side
what about some of the side effects? The most common side effects with all 4 agents occur at the time of the injection. So injection site reaction. So with the subcutaneous forms, local injection site reactions with redness and swelling. Now, as Asen mentioned, actually it improved with time. A lot of patients, they get the hang of it or your body adapts to it. Similarly with the intravenous form, which is Remicade, a small percentage of patients get infusion reactions. They get a lot of flushing when we treat that very successfully with antihistamine. So the early side effects from the injection seem very manageable. It's a very rare patient where we actually have to switch the agent because of just the acute local reactions. Dizziness, it's unusual. I agree with your comment. We watch our patients very carefully. A very small percentage of patients have had some sensation of dizziness after the injection, but the general pattern in most patients is with longer use, that gets better, actually. Yes?
This is actually for her.
Sorry?
If we were going to set up a home gym, because we set up a home gym,
Yeah.
that made sense. You can't get to the gym,
Sure.
bring the gym to you. What would you put in it?
So you hear the
We have an
question?
elliptical and an inversion table and some hand weights.
So you hear the question? So it's a question for Laura. What kind of, if you were setting up a home gym, what would you put in it?
Just something that you could fit into.
How about a 100-meter
bedroom
pool?
of a one-bedroom apartment.
I think that the majority of the exercises that you need to do can really be done with very little or no equipment. So for example, the stretching exercises and a lot of the stretching or strengthening exercises can be done simply on the mat or the floor. You can use a ball, like I mentioned, to focus on more of the core strengthening.
Kickball question, can cats get through them?
I'm sorry?
Cats,
Can cats get
through the ball.
through the ball? Wow. Can they? I don't know.
We've been thinking about a ball, I've been thinking I should get a ball and then.
They'd have to have pretty sharp claws, I would think, but it's possible. I don't know. And in terms of the cardiovascular workout, I mean, a lot of that you can do, you know, you can walk, you can cycle. If you want to get like a stationary bike or something like that, so if you don't want to go outside in the winter, for example, maybe that's something you might want to invest in. But I don't think you need to invest in a lot of money to set yourself up adequately.
So I'm aware of the time. If there are any remaining questions, Laura and I will stay down here at the front. I'd particularly like to thank Asen and Shira, I think, for our patients for taking an active role. Fantastic. And we always thank our pharmaceutical partners, and Maria Morales, who I think is probably gone, deserves a special. She probably did your registration. Or events like this. In fact, Maria actually coordinated the Newfoundland and Alberta meetings as well from her home base here. So I'd just like to acknowledge a wonderful contribution from Maria. Thanks very much for coming. We'll hopefully have some feedback from you on the questionnaires, because we'd like to design this to meet your needs the next time we do it. Thanks very much.